My name is Portia Kalun, and I am a PhD student at McMaster University in Hamilton, Ontario, Canada, as well as one of the co-authors on the review entitled Surgical Simulation Training in Orthopedics Current Insights. Although there is ongoing development of new techniques for orthopedic trainees to learn, there are decreased clinical learning opportunities due to factors such as duty hour restrictions and pressures to increase operating room efficiency. Simulation is an appealing teaching tool to increase trainee exposure to different skills, with no impact on patient care. Simulation also allows us to adjust the fidelity or realness of a task depending on the level of the learner. In other words, we can simplify more complicated tasks into simpler components for novice learners, and as trainees get more familiar with the tasks, we can make them more similar to real-life or clinical situations. Despite these benefits of simulation for learning, there has been little evidence published that training in simulation actually improves clinical performance. It is also unclear how much weight should be given to performance assessments that have been conducted in simulation. For example, if someone scores high on a task in simulation, does that mean that they are ready to perform that task on a live patient? Given this, we decide to conduct a scoping review to explore whether skills learned in simulation-based settings results in improved clinical performance in orthopedic surgery trainees. We included 11 review papers and 4 experimental studies discussing transfer of skills in orthopedic trainees from simulated to clinical settings. Out of the 4 experimental studies, 3 demonstrated transfer from simulation to the clinical setting. However, there were methodological issues with these studies. Furthermore, many of the review papers found little evidence of transfer of skills from simulation to the clinical setting. In fact, many papers they reviewed demonstrated transfer of skills to other simulators, which may not be as clinically relevant when the end goal of simulation training is to improve performance in the clinical setting. Studies also commented on the need to define competent performance on a simulator, including how many simulation sessions it takes to facilitate the transfer of skills from simulation to the clinical setting. In addition to these points, we also noted that not all papers commented on the fidelity of specific simulator models, so it is unclear whether transfer of skills from simulation to the clinical setting differs between low and high fidelity models. We also suggest that, when measuring performance in simulated and clinical settings, educators are mindful that validity is context-specific, meaning that a tool validated in a simulated setting may not also be valid in a clinical setting. This is important when comparing performance in both settings to establish transfer of learning. In conclusion, our review identifies weak evidence as to whether skills learned in simulation transfer effectively to clinical practice for orthopedic surgery trainees. Given the increased reliance on simulation, more research on the transfer of skills from simulation to the clinical setting is needed to ensure that simulation training is incorporated effectively into orthopedic surgery training programs.